Hello and welcome, dear students. And anatomy series is going on, as you know. Today we'll be dealing with very important two topics, which have been actually the reason why you've been requesting me for taking anatomy series in the first place. Today we'll be talking about the anatomy of bladder and that of ureter. I've tried to include good pictures as much as possible to tell you about the anatomy of bladder. I'll try to hold physically as well. Try to tell you how the relationship of the bladder is in the pelvis, and I'll also try to use certain videos which I've got from the net to in order to tell you the relationship and the complex anatomy of the ureters, which we all gynecologists we dread. Before we get to this video, there are certain important announcements I'd like to make. Complete course is going to be updated very soon, and updation means it's not just going to be one or two topics; it's going to be entire course update. That means all those topics which you would be requesting me to take separate notes on. There was a couple of students who wanted more of notes. There were some of them who wanted more of videos. I have encompassed both in the new schedule of my complete course. So, guys, all of you who are now preparing for the June theory exam, it's high time you should now concentrate, on your theory properly. Go through all the important details. Like in my notes, they're mostly very crisp. They are up to the point, and they are the ones in which you cannot miss them if you want to crack the theory exam. So you have to go through at least that part which I have given in my notes. And of course, I've got my answer bank. That is the second announcement. The answer bank has been updated. The December 2022, that is this December which is gone. That paper has been now updated in the answer bank, and it's already there available to be purchased. The students who've already taken my answer bank before will automatically see their updation in their respective apps which they've already subscribed to before. So they'll automatically, it will get updated. That is the advantage of taking it beforehand. So these were two important announcements to be made. The others, the other, there's one more announcement. Third and most important, the vaginal hysterectomy has been the workshop has been now completed and updated on the app as well. So all those students who were there with me for the live classes in my Telegram channel have already mostly seen all the videos. But the ones who missed it, the ones who did not know that there is a vaginal hysterectomy going on, well, you can go ahead and purchase it. It's available in my app, and rightly so, because the videos are fantastic. I'm very proud of the way certain videos I have borrowed, but certain videos are my own, from my own OT, and they're beautifully given, giving you and delineating each and every plane. So please go out and learn yourself, because you have to be a surgeon one day, and nobody will give you any marks for being a lousy surgeon. You'll get into more of trouble. So when you have to learn, you have to do, you might as well do it right. And for that, you need to see right and learn right. And only then you'll be able to do it. So let's now proceed forward with the video today. So what you can see right now is a little bit of about the urinary bladder. Now, urinary bladder, the things you already know, I'm not going to tell you again. It's a triangular organ, it's a hollow organ, it's a right behind the symphysis pubis. So I've made this kind of balloon. If you remember, I had taken in a video which described the relationship of ureters with uterine artery, which is there currently also there on the YouTube. Please go ahead and check it out. It's a very very important video. I'll give the link in the description. Just go and check it out, because it's a very important video to be seen to understand the relationship of ureter and uterine artery, which is not the agenda in this video currently. Right now, I'm going to be focusing more on the anatomy of and the relationships of the ureter with the surrounding structure, and of course the bladder with the surrounding structure. So if you consider this balloon as the bladder, then I'll tell you what exactly happens. Of course, it's got a capacity to have urine filled inside. On 100 ml capacity, the first wave, it goes to the brain that you have to now think about voiding the urine. And the capacity 300, you are uncomfortable, you want to micturate, and you do usually between 200 to 300 ml. And of course the the maximum capacity till 500 to even 800 ml of urine. So of course that will be too much distension, and obviously with a lot of discomfort. So now let's see first and most important, the parts of the bladder. They're divided into a base and a dome. So if you see why I've taken this balloon is that I'll put it up close. It's actually kind of triangular, shape. This it becomes the superior surface, okay, or something like a dome. Okay, over here you have the attachment of ureters coming. Okay, here the ureters, they attach exactly like this. So this becomes more of a base, okay, at the level of ureteral orifices. And these two, they are infralateral surfaces. They are infralateral surfaces, and this becomes the apex. If you can see, this is the apex. So how it is usually there in the pelvis is something like this. This is the pubic bone over here. This is the pubic bone. So it's right here. The apex is right here. Okay, and this is where the pelvis is actually pretty small. So I'll now try to show you. So this is where, here is where the two ureters are attached. If you can see it, yeah, somewhere over here the ureters are attached. So they come from here, but they go like a bowl and they attach over here, correct? And the ureter and the apex, this apex is right close to the pubic symphysis, as you can see over. And this space, can anybody tell me the name of this space? This is called the space of Ridgius. The, just retropubic space, or the space of Ridgius. Why is it important? Is because so many operations that we do, the sling operations, the operations, not for the prolapse, but to correct the urethrocoel, if at all, or to improve the stress urinary incontinence, they are done in this space. Okay, so I'll be dealing with those operations also. In fact, one of my lectures I have spoken about these operations. But yes, of course, these are the certain few operations that you do to correct the urethrocoel, or to improvise the stress urinary incontinence. You move in that space, the space of Ridgius, or the retropubic space. So what I was trying to tell you is that this is the bladder, this is the apex, this is the infralateral surfaces, both the sides. Here is where the ureters, something like this. This is how they attach to the bladder. This becomes the dome, and this becomes the base. Now, obviously, you'll understand it automatically that, dome happens to be thin walled. This is the most distensible part of the bladder. Okay, this is the one which keeps rising. And what I was trying to tell you in this pelvis is that, see, up till now, the bladder is like this, it's a pelvic organ. It's a pelvic. But when it starts distending, it becomes like this, it's now the abdominal organ. And sometimes when you do cut, sometimes when you cut over here, especially low phalansteal incisions that we gynecologists give, and if the nobody has put the Foley's, which is actually a blunder, you can injure the bladder while in your first cut, while you're cutting the peritoneum. Sometimes even in second cesarean sections, third cesarean sections, the bladder is so pulled up, because somebody has pulled up the peritoneum and stitched it, that the first time you enter the abdominal cavity, it has happened with me as well, that cutting the peritoneum, I was so very confidently cutting, and my cut was also not low down. See, the first incision that you give is low in the abdomen, and then you go a little higher when you're cutting the peritoneum. I was cutting high up, but the bladder was so pulled up that it didn't feel like I'm going to cut the bladder, but it did happen. It was injured, and it was a cut through and through, and then we had to go ahead and repair it. So this I'll talk about later for the applied anatomy, but right now just know that after it fills up, that's why you need to put Foley's. Um, After it fills, this is like almost a distended bladder, which you can see, which will be more like this. Then it will be like this in the cavity. Correct? It will be like here, mostly here. So what you do is, with the help of Foley's, you just deflate it and become something so unremarkable, something like this, and it keeps pushed over here. And you can, of course, get more space to do your surgeries. So now let's go back again and understand the relationships of this bladder. So this is this place. See, otherwise it's like this, So the only place that can distend will be this, right, on the top. So this is what I'm trying to say. The bladder can be divided to base and dome at the level of ureteral orifices. The base of the bladder consists of the urinary trigone posteriorly and a thickened retrusor anteriorly over here. So this is mostly the base. What I'm holding right now is actually the base. And the other part which you can see above is actually the dome. So the three corners of the trigone, they are formed by the two ureteral orifices and the opening of the urethra into the bladder. It has got a sympathetic innervation and is responsible for maintaining the continence. So sympathetic system has sympathy with you. It will not let the bladder void. Parasympathetic system is the one which lets the bladder void. We'll get to it later. So the dome of the bladder is thin-walled, It's the distensible part of the bladder, above the bladder base. It's got parasympathetic innervation and is responsible for micturition. Okay. Now it's other part. This is looking like a apex, isn't it? So I've made it in such a way that it looks like an apex. This apex lies posterior to the upper margin of pubic symphysis, and right here between the pubic symphysis and the apex is the space of Ritzius, in which you have those MMK operation. If you remember, I think I must have told you those kind of operations are performed here, so that there is this stress urinary incontinence or the urethrocoel or whichever laxity is there, that can be stretched, and you can have the patient can be improvised if at all there is stress urinary incontinence, proven stress urinary incontinence alone because of urethrocoel. Only then you have to perform such an operation. uh, so this is at the pubic symphysis. Lower pass is mostly the fixed part, neck, from which the urethra arises. Okay. Now let's see, you yourself are going to tell me the relationships. Of course, if you understand this anatomy, you will be able to understand the relations. It's not a big deal. What about the anterior part? If I ask you, anteriorly the bladder, what is the relationship of anterior part of the bladder? Answer is the anterior abdominal wall is related to the anterior part of the bladder. That's okay. You can even say pubic symphysis anteriorly, but anterior abdominal wall, right? Because when it inflates, it becomes like this. This is the abdominal wall, and this is your bladder. So when you cut over here and you go inside, you can rupture the bladder. Even when you're taking the peritoneum, right? Do not take deep bites towards the lower part of your peritoneum. Okay. I think you must have seen my C-section workshop, and by now you guys are experts in doing C-section. Because at every step of the way, I think I've included all kinds of cesareans as possible. The breech extraction is there, twins is there, you have bladder dissection is there, previous C-sections is there, along with ligation it is there. I think only Padvardhan I am yet supposed to be adding. I'll add it pretty soon. Otherwise, everything is there. Difficult head delivery is there. Free floating head is there. Deep transverse arrest is there. Everything is there, and you need to learn these things, because sooner than later you will be performing these C sections. So might as well do it right. So in that case, I have tried to explain to you why not to go too deep, why not to go too up, why not to always see your last stitch, especially on the peritoneum. Why? I'll tell you, because of this bladder right there. Okay, it gets pulled up. So anteriorly, it is connected with the anterior abdominal wall. Posteriorly, where do you think it rests? Think about it. Just think about it. It's against the cervix and vagina. What do you have over here? You have the uterus, which is just literally lying like this. This is the cervix, and the uterus is almost like this on the bladder. This is your anterior abdominal wall, and here is your uterus. Okay. And then what do we have? What about the other relationships? So you have, see, this is the figure I want to show you. So this is the apex over here. This is the superior surface, the infralateral surfaces, the posterior border, and these of course the lateral border, and this is your base. Can you see the fundus, the base, the posterior surface? It's all one and the same thing. But just imagine the fundus name is so confusing. This is the fundus of the bladder, the posterior base of the bladder actually. So it was just to show you once. Now infralaterally, here, what do you have? It's in contact with the inner surface of the pubic bone. So it's almost like this. It's almost like this, This is what they're trying to say. They're saying the infralateral surface is actually related to the pubic bone. If at all you're putting it like this, a full inflated bladder probably they're talking about. It is something like this. Wait, I'll show you. Something like this. So the apex is somewhere here in contact, the anterior surface, or let's say the anterior surface. Okay. The infralateral surface is somewhere still touching the pubic bone. You can't actually demarcate it so nicely, because it's the apex actually which is coming. So anteriorly, how can you say? There is no anterior, there's just an apex, right? So apex ko aap kaise, just an apex, you can't say anterior, right? The entire this thing becomes the anterior surface. Over here and over here, these both are actually anterior surface. Over here you have the abdominal wall, and over here you have the pubic symphysis, right? So there is no hard and fast rule over here, guys. There is no hard and fast rule over here. So anyways, now you know what are the relationships. Histologically, how many of you really know about the bladder histologically? You know something about transitional cells, right? So I'll tell you a little more. It's not usually asked and not expected from you, but since bladder cancer is getting more and more common, and its histopathology is very, very important. Plus the histopathology, if you get to see some cells which are transitional epithelium, you will obviously think about a bladder involvement, and at the same time there is a spread, there is mets involved, so you should know a little bit about the histology of the bladder because of the specimen comes out to be having transitional cells in it. You will at least have a mind going towards the bladder surface because that's the epithelium there. So the outermost is complete serous peritoneum or the fundus superior surface. So basically the peritoneum is covering only the superior surface, right? So it's complete. It's incomplete serous. So peritoneum is lying only on the above, the anterior upper surface, right? Not the lower surface. The muscle layer, it consists of coarse bundle of smooth muscle fibers known as the detrusor muscle. By now you know that. And very ill-defined three layers are there. There is outer longitudinal, middle circular, and again inner longitudinal. So these are the three layers. Again, I'll say outer longitudinal, middle circular, and again inside again you have more of longitudinal layer fibers. Current thinking is that instead of layers, they are intermeshing muscle fibers like you have in case of uterus, but there are more in uterus. Here you have still delineated. Mucosa of the bladder contains the transitional epithelium. It's got no glands and is plexiform with trabeculations as seen in cystoscopy. So you must have seen in cystoscopy at least people. You must have seen at least once in your life the cystoscopy, or if you've not seen, just go ahead and see it on YouTube. There are many videos available on cystoscopy. So in on cystoscopy, you'll get to know that there are trabeculations inside. Okay, and that's how it looks. The transitional cell epithelium of the bladder. Then I will talk about the blood supply. So you just imagine what could be the blood supply to the bladder. Think about it first, and then I'll give you the answer. It's a superior vesicle. This is vesical artery basically, right? So superior vesical artery, a branch of umbilical artery. Inferior vesical artery, a branch of internal pudendal artery, or the vaginal artery. Uterine vaginal arteries may also contribute. So basically, superior vesicle and inferior vesicle. Let's not confuse yourself any further. Of course, inferior vesicle is more prominent because it's a branch of internal pudendal. And like I told you sometime somewhere, that when you come to perineum, mostly pudendal nerve is the one which supplies all of them, and pudendal nerves branches, and pudendal artery and pudendal arteries branches. Right? What about the venous drainage? Again, venous plexus drains into the internal iliac veins, and lymphatic drainage is into the internal and external iliac lymph nodes. Abhi, we're talking about the inside, right? We're talking about the bladder. We've not yet gone to the inguinal area or the perineal area. We're still there inside the pelvis, and over there mostly the internal and external iliac lymph nodes. They are the ones which drain most of the organs over there. So that was about the arterial supply. Let's talk a word about innervation, which is very important in this. Why? Because three kinds of innervations are there. Of course, you've got the sympathetic, you've got the parasympathetic, and of course, you've got the pudendal innervation over there as well. And why and how, I'll tell you. The nerve supply to the bladder is from the vesical plexus, okay, which is a component of the inferior hypogastric plexus with the contribution from the uterovaginal plexus. And the sensory supply is through the sympathetic component, so T12 to L2S spinal segments, which carry painful sensation of over distension. So they are sympathetic, sympathy, no bladder contraction as of now. You cannot void, right? The detrusor muscle, this is supplied by the parasympathetic component of the spinal segments through the pelvic splanchnic nerves. Okay, and the sympathetic nervous system, hypogastric plexus, which is written over there, right? So you should also just not the fact that it's supplied by both parasympathetic sympathetic system. That's not the information which is expected from a postgraduate student. You should know what I'm talking about. So if I'm talking about this parasympathetic innervation, you have to say parasympathetic innervation. That means I'm talking about pelvic splanchnic nerves, nervi erigentis. If I'm talking about the sympathetic nerves, I'm talking about hypogastric plexus, right? And a sympathetic nervous system does not let void. Sympathetic system is drawn and made in such a way that whenever the impulses strike at the right time, obviously looking at the social situation, the voiding does take place because you've got voluntary muscle and voluntary control of the muscle of the sphincter of the urethra. The sphincter urethra is under the control of parasympathetic system, and which is why the person in question does void when they see the socialistic situations ideal. Okay, so it helps in urinary evacuation by contracting the detrusor muscle and relaxing the internal sphincter, or just relaxing the voluntary sphincter of urethra, right? Because that's under the control of parasympathetic system. Okay, what is the development of bladder? It just develops from the upper part of urogenital sinus. That's enough for your stage. Okay, what about the functions of bladder? Come on, that you know, it is responsible for collection of urine, for evacuation of urine. Okay, on collection of about 300 ml or more from the past 4 5 hours, sympathetic nervous system, they carry the sensation to the brain. The voluntary control of cortical center restrains the spinal micturition center from S2, S3, S4. On finding a suitable place for micturition, the cerebral restraint is lifted, sacral spinal micturition center through parasympathetic nerves. It causes the contraction of the trusor muscle and relaxation of the sphincter with the flow of urine. And you should know the two plexuses through which these two exercise. Applied anatomy. Do I need to really say this? Applied anatomy. I think you all really know. Applied anatomy means I'm talking about the bladder injury. I'm talking about the where and how the bladder can be injured. I've just spoken to you. Don't you think when you're dissecting the this retropubic space of radius as the most dangerous place for causing an injury in the bladder? Yes. If you've not placed Foley's properly, the bladder can be injured if you're dissecting too close, especially if you're doing vaginal hysterectomy. It's a good amount of possibility of bladder injury. If you're doing a previous cesarean section and then another C-section is going on, the bladder is adherent, advanced, there's a chance for injury. If you're doing hysterectomy in a patient with previous 2 3 C sections, there is a more chance of bladder injury. Bladder does get injured even in case of advanced labor. If there is neglected labor, now it's not so much, but yes, deep transverse arrest for a long time, patient has been arrested, the bladder injury can take place. Even fistulas do take place that way. And very important, can you see the third line? Vesicovaginal fistula may be formed in injury to the bladder during obstructed labor or even during surgery. In one of my videos, I think when I was talking to you about, there was a lecture I took on rectovaginal fistula, okay, in which the starting line I told you the reason behind the rectovaginal fistulas. And in the similar way, you have vesicovaginal fistulas. In case of developing nations, more chances are obstetric vesicovaginal fistulas. In developed nations, more chances of hysterectomy followed by vesicovaginal fistulas. So you should just be mindful, watchful, and have a great diagnostic power to understand and locate not just the size but also the site of vesicovaginal fistula, which is a very important anatomy, applied anatomy in the discussion of bladder. So next segment will be upon ureter, its relationships and its anatomy with the video. So just stay tuned.